Bismillahirrahmanirrahim. Now we are starting off with the fifth session of reproductive unit. So in this session we will talk about episiotomies. So in episiotomies, used to enlarge the vaginal outlet to facilitate the delivery and reduce the risk of severe third or fourth degree perineal laceration. Types are mediolateral and midline. So here you can see a mediolateral episiotomy in this direction, like if we come straight downwards, like in this line. So that is called a midline episiotomy. Let me remove that. So that is midline episiotomy. Then there is operating scissors and frontal head bulging outwards and fetal head bulging out, and then this is vaginal opening. So there can be either two types, mediolateral and midline. So the midline episiotomy, vertical incision from the posterior vaginal opening to the perineal body. So it does not involve the perineal body, it is until the perineal body. It transects the vaginal lining and submucosal tissue similar to a second degree laceration. As you can see in this picture, the second degree laceration is over here. Like this picture is second degree laceration, in which there is laceration to the vaginal mucosa, and that also involves the perineal body. So but it is similar to the lining, similar to the second degree laceration, but not external anal sphincter rectal mucosa. So it transects the vaginal lining and submucosal tissue as well, and it looks something similar to the second degree laceration. So I guess perineal body is also involved maybe, but it does not involve the external anal sphincter or the rectal mucosa. Improper repair of a midline episiotomy or second degree laceration may result in a pelvic organ prolapse or dyspareunia. So both of these things can happen, and they ask you frequently about this episiotomy in the Uworld questions, and maybe there is a question in step 1 exam. So there is this may result in the pelvic organ prolapse and dyspareunia. Moving forward to the pelvic infiltration. So what is that? Pelvic innervation. The pudendal nerve S2 to S4 root values. The function is sensory, that is perineum. So it provides sensory supply to the perineum, and the motor is urethral and anal sphincter, the pudendal nerve. Then lateral femoral cutaneous nerve L2 to L3. It provides sensory supply to the anterior and lateral thigh. Inferior gluteal nerve L5 to S2. It provides motor and gluteus maximus. Genitofemoral nerve, the root values are L1 to L2. Sensory scrotum, labia majora, and medial thigh are the so genitofemoral nerve is also a sensory nerve, and that provides sensory innervation to the scrotum, labia majora, medial thigh, and stuff like that. And obturator nerve L3 to L4. Sensory is medial thigh and motor is adduction. And iliohypogastric T12 to L1. Sensory and suprapubic. So sensory and suprapubic. So these are the things. So let me see, the only exclusively motor nerve is inferior gluteal nerve. This is motor. Then we have mixed nerve, like the pudendal nerve is sensory as well as motor, and the obturator nerve is also sensory as well as motor. Yep. So sensory as well as motor. So the only exclusive motor nerve to the perineum, to the pelvic area, is the inferior gluteal nerve that provides motor innervation to the gluteus maximus muscle. And then we have pudendal nerve and obturator nerve, which are partially motor, like they perform motor function, like obturator is for the adduction and pudendal nerve is for the urethral and anal sphincter patency. So see this table please. Now we look at the pudendal nerve. Pudendal nerve is sensory plus motor, so it's a mixed nerve. Sensory supplies to the perineum, and the motor supplies external urethral and anal sphincters. Cause of injury is stretch injury during the childbirth. Okay, so during the childbirth, the most common, I don't know if it is the most common or not, but it can be injured during the childbirth. Stretch injury during the childbirth. If there is an injury, so what will happen? There will be decreased sensation in the perineum and genital area. They sometimes refer to it as a saddle-shaped area of anesthesia in the perineum. Can feel fecal or urinary incontinence. It can cause fecal or urinary incontinence. Can be blocked with a local anesthetic during the childbirth using ischial spine as a landmark for injection. Then we have pudendal nerve block. So here you can see that we are using the ischial spine. We are using ischial spine as a landmark for the injection. So if you can, if I could zoom it in here. So here you can see that this is the ischial spine. Okay, so it is the ischial spine, and we are using the ischial spine as a landmark, and then we are inserting the pudendal nerve. Basically passes below the sacrospinous ligament in front, or maybe under the ischial spine. So we use a local anesthetic in that particular region to avoid the labor pain. So here you can see now that pudendal nerve landmarks are ischial spine and sacrospinous ligament. Complications: the internal pudendal nerve artery and inferior gluteal artery which run medial to the pudendal nerve, internal pudendal artery and the inferior gluteal artery which run medial to the pudendal nerve. Inadvertent injection into these vessels can lead to hematoma or arrhythmia from intravascular infiltration of the local anesthetic. So whenever there is an intravascular infiltration of the local anesthetic, suppose we were giving a local anesthetic and that entered the circulation. So what is local anesthetic? Local anesthetic is a sodium channel blocker. That sodium channel blocker may enter the heart, and there they can cause, because the pacemaker cells like SA node and the AV node, their depolarization is dependent on sodium, like they undergo sodium dependent depolarization, and if the sodium channels are blocked in those areas, so the person may undergo development of arrhythmias, or maybe a hematoma can form in a milder, but that is also a complication. So if the as a complication of the block of what, as a complication of the pudendal nerve block, there will be hematoma or arrhythmia if the local anesthetic touched or entered the inferior pudendal artery or the inferior gluteal artery, like these two arteries over here. Moving forward, we have the genitofemoral nerve, the L1, L2. So the genitofemoral nerve L1, L2 courses along the anterior surface of the psoas muscle. So where is the psoas muscle? The psoas muscle is like over here. So this is psoas muscle. Let me zoom it in. So here you can see the psoas muscle. So what are we reading about psoas muscle? So the psoas muscle, what is it? So it courses along the genitofemoral nerve. It courses along the anterior surface of the psoas muscle. It is sensory to scrotum, labia majora, and the medial thigh. Injury from the abdominal retractors during the laparotomy. So laparotomy will damage the genitofemoral nerve. These are some buzzwords, like whenever you think about a childbirth or a delivery, and then the patient is presenting with the incontinence along with a saddle shape anesthetic area of anesthesia. So think about that one, the pudendal nerve, and if there is the sensory loss, or if the person is having some condition that is associated with the laparotomy and now he is having symptoms. So think genitofemoral nerve. Keep it high on your differential, because it can be anything else, but think of it as well. So here you can see this is the psoas muscle over here, and it courses along the anterior surface of the psoas muscle. So where is genitofemoral nerve? This is the genitofemoral nerve, and this is coursing along the anterior border of the psoas muscle. Injury to the abdominal retractors during the laparotomy. Injury will lead to labial and scrotal anesthesia. Decrease anterior thigh sensation below the inguinal ligament. Okay, decrease the anterior thigh sensation below the inguinal ligament, and then we have absent cremasteric reflex as well. Iliohypogastric nerve. So the iliohypogastric nerve T12 to L1. Where is iliohypogastric nerve? There is a diagram of that or something. Iliohypogastric nerve. This is iliohypogastric nerve. So the root value for the iliohypogastric nerve is T12 to L1. Sensory supply suprapubic region, and the motor supply to the transversus abdominis and internal oblique muscle. So it provides sensory supply to the suprapubic region and the motor supply to the transversus abdominis and the internal oblique muscle. The cause of injury is abdominal surgery. Presentation of comment is burning or tingling pain in the surgical incision site radiating to the inguinal and suprapubic region. So the iliohypogastric nerve, the root value is T12 to L1. So it provides sensory innervation to the suprapubic region and the motor innervation to the transversus abdominis and the internal oblique muscle. It is damaged during the abdominal surgery. Okay, and the presentation, burning or tingling pain in the surgical incision site radiating to the inguinal and suprapubic region. There is a Uworld point, injury during the closure of the, I don't know what that is, P fenestral skin incision in the C-section. So let me look at that. It is P fenestral skin incision. Okay, let's select that. The P fenestral incision, it is the name of an incision firstly, and it is an incision of the pubic incision, a type of abdominal surgery incision, blah blah blah. So we do that incision in the case of C-section. So we perform this incision over here. So it goes something like that. So during the C-section, we do the P fenestral incision. Okay, let's move back to a PDF. So here we have the thoracoabdominal nerves T7, 8, 9, 10, 11, and the root value T12, L1 is for the iliohypogastric nerve, And what are we talking right now? Iliohypogastric nerve. Okay, so iliohypogastric nerve, and that can be damaged in the prefenestrial incision. Suppose we are giving an incision like this. For the C-section, we gave an incision like this. There is an incision. There is an incision. Suppose we gave an incision something like this, something on those lines, and that incision can lead to the damage to the iliohypogastric nerve. Okay, moving forward. Now we have the obturator nerve, that is the root value L2 to L4. So the innervation is, it provides sensory innervation to the medial thigh, and motor function is obturator externus, adductor longus, adductor brevis, gracilis, pectineus, adductor magnus. It can be damaged during the pelvic surgery. Presentation is decreased thigh sensation, medial and adduction. Uworld point is injury during the retroperitoneal pelvic lymph node dissection. So retroperitoneal pelvic lymph node dissection can result in the medial thigh sensation loss and inability to adduct the thigh. So obturator nerve can be damaged during the retroperitoneal pelvic lymph dissection. So if there is retroperitoneal pelvic lymph node dissection, that can lead to the injury and can result in the loss of medial sensation and ability to adduct. So it can lead to loss of medial thigh sensations and ability to adduct the thigh. So here we have the female reproductive epithelial histology. It is kind of important. You must remember that which area has which kind of epithelium in that. So for this one, we will go from below upwards, maybe that will be good, I guess. Simple columnar, yeah. So we'll go from in this direction. So firstly, in the vagina, the most external structure, we have stratified squamous non-keratinized epithelium. It maintains the acidic environment and prevents the infection. The cervix. Now there is one thing that we call ectocervix and then endocervix. So we'll talk about ectocervix first. It also has stratified squamous keratinized epithelium. So these two things which I've highlighted with a red pen. So these are containing the stratified squamous epithelium, the vagina and the ectocervix. Then as we move toward the endocervix, it becomes I guess there is a picture as well. There's another picture. So as we move to the endocervix, it becomes simple columnar. So I will use like a different color, maybe purple. So there we have a simple columnar epithelium. So there is the transitional zone. Suppose that this is vagina. Suppose this is vagina and vaginal epithelium. Forget about vagina. Suppose this is ectocervix and we have like stratified squamous epithelium which looks something like this, and we have stratifications and multiple layers of squamous epithelium, one on top of other, and stuff like that. And then comes the endocervix, and in the endocervix we have simple columnar epithelium, and simple columnar epithelium like columns of cells. So let us choose a color and then I will draw that. So in the simple columnar epithelium there is like columns of cells, simple columnar cells like this, and just at the junction of both of them we have a transition zone. Like there are columnar cells along with some stratified cells, and this is a hybrid zone where there is columnar or squamous epithelium. This particular zone is called the transition zone, and this is the site of infection of the HPV or the cervical cancer. The most favorite site for the cervical cancer is this one. So here we can find the cervical gland secrete the mucosa. Cervical gland will secrete the mucus, thin watery mucus during the ovulation, mucus plug in pregnancy. HPV infection predisposes to the cervical malignancy. HPV infection will predispose to the cervical malignancy. Okay, so cervical gland secrete the mucus, thin and watery during the ovulation, and HPV infection predisposed to the cervical malignancy. Then we have uterus, simple columnar, for example the endometrium. Okay, so let's continue with it. Okay, give me some time to make a color difference. So here we have it, like blue color maybe. Okay, so the simple uterus contains simple columnar endometrium. So simple columnar endometrium is just like the endocervix. So uterus also contains a simple columnar epithelium, that is simple columnar epithelium. For example the endometrium. Stratum functionalis sloughs off during the menstruation. You must remember that the stratum functionalis is the layer that sloughs off during the menstruation, and prolonged estrogen exposure prevents the shedding, resulting in the hyperplasia and malignancy. So if the person, like the female, is on the estrogen replacement therapy, so she has an increased risk of developing the endometrial carcinoma. Then fallopian tube contains simple columnar epithelium. Ciliated cells transport the egg and embryo. Damage can cause infertility, hydrosalpinx, and ectopic pregnancy. And then we have the ovary, which contains the simple cuboidal epithelium. So let's make it like yellow. So ovary contains simple cuboidal epithelium and rapidly proliferate to repair the ovulatory surface defects. So now we are having vagina and ectocervix with the stratified squamous epithelium, endocervix, uterus and fallopian tube with the simple columnar epithelium, and ovary with the simple cuboidal epithelium or the germinal epithelium. It is also called as germinal epithelium, and germinal epithelium for the ovary is simple cuboidal. I guess it is simple cuboidal elsewhere as well. Okay, so now we are talking about male reproductive anatomy. So let's see the structures. It is ureter. That is not important. Let's see the structure. This is testes and then scrotum, and then we have the bulbourethral gland of Cooper, like over here, and the prostate is present over here, like just at the neck of the bladder. Then the prostate is there, and then we have the ejaculatory duct. Okay, so this is the ejaculatory duct, and this is the seminal vesicle, and after the seminal vesicle, this is the vas deferens over there, and then we have urethra and corpus cavernosum. Then epididymis is over here, then prepuce, and then glans penis. And the cross section of the testes will show vas deferens. So then there will be rete testes, efferent ducteus will be there. Head of the epididymis, I ask you sometimes about these anatomic points. Then septations, which are going into the parenchyma of the testes. Then seminiferous tubules are over there. Then tunica albuginea is also present, and the tail of epididymis is something like that. Pathway of sperm during the ejaculation. So 7-Up. 7-Up is a beverage used in Pakistan very commonly. So 7-Up, seminiferous tubules, epididymis, vas deferens, ejaculatory ducts. N is for nothing, and then urethra and penis. So from the seminiferous tubule, so if I could see that, from the seminiferous tubules inside that one, then that goes to the epididymis, like this is 2. This is epididymis, right? Head of epididymis. So this is epididymis 2. Then from the epididymis, it moves to the vas deferens, like this is 3. From epididymis it is going to the ejaculatory ducts. The ejaculatory ducts are over here, like over here. So this is 4. From ejaculatory duct it is going to the urethra. That is, this is point number 5. And then we have N is for nothing, then urethra, and then ultimately the penis. So this is the penis, like this is 6. So this is 6. So these are the 6 points where the 7-Up goes. Then we have anatomy of the penis. So the anatomy of the penis is that composed of 3 cavernous bodies: the corpus cavernosa, the 2 large spongy tissue beds. Okay, so the corpus cavernosa, where is the corpus cavernosa? This is the corpus cavernosa. These are located bilaterally, I guess, and these are the 2 large spongy tissue beds. And then we have corpus spongiosum, which is smaller spongy tissue bed that surround the urethra. So in this picture you can see the corpus cavernosum is over here, like this is the corpus cavernosum, this one and this one. And then we have the corpus spongiosum that is surrounding the urethra over here. This is corpus spongiosum which is surrounding the urethra over here. So just keep this in mind that there are 2 corpora cavernosum. So there are 2 C's in the corpus cavernosum, C. So there are 2 corpus cavernosum, and corpus spongiosum has only 1 C. So it is like 1, or remember it whatever way you want. So corpus cavernosa, 2 large spongy tissue beds, and corpus spongiosum is a smaller spongy bed that surrounds the urethra. Tunica albuginea. Tunica means covering and albuginea means white connective tissue covering the surrounding of the corpus cavernosa. So you can see there is a white covering that is surrounding the corpus cavernosa. I will highlight that and I will then delete it. So this particular covering around the corpus cavernosa is called as tunica albuginea. It is a white connective tissue which is covering or surrounding the corpus cavernosa. Localized fibrosis in the tunica albuginea lead to the Peyronie disease. Peyronie disease. I guess we will study that in the future pathology sections. Peyronie disease. Yep. Yeah, that is like I guess abnormal bending of the penis or something. So that is called as Peyronie disease, and the localized fibrosis in the tunica albuginea is causing that. Rupture of the tunica albuginea may occur in the fracture of the penis. Okay. Then what is Buck's fascia? So covers all the 3 erectile structures. So Buck's fascia is covering all the 3 erectile structures. D for Buck fascia, as you can see this one. So the Buck fascia is covering the corpus spongiosum along with the corpus cavernosa, the corpora cavernosa, like that, because there are 2 of them. So that is the Buck fascia. So the Buck fascia covers all the 3 erectile structures. So these are the 3 erectile structures: the corpus cavernosum and the corpus spongiosum. So here there is, I don't think there is any other important thing. Tunica albuginea is that white one, and Buck fascia. And then there is also a superficial that is called the Dartos fascia, and then we have the skin. And under the Buck's fascia there are like the deep dorsal vein, dorsal nerve, and dorsal artery as well. And deep artery is present inside the corpus cavernosa as well. So deep artery is in the corpus cavernosum. So corpus cavernosum contains deep arteries, corpus spongiosum contains urethra, and the Buck fascia contains these structures along with deep dorsal vein, dorsal nerve, and dorsal artery. Okay, so moving forward, we have Peyronie disease. So the Peyronie disease is the abnormal tunic albuginea localized fibrosis of that. Localized fibrosis of the tunic albuginea will lead to Peyronie disease, as you can see in this picture. There is a localized fibrosis of over here. Firm outer casing where the plaque forms Peyronie disease. So in the Peyronie disease, fibrous plaque on the corpus restricts the symmetrical erection and acts like a tether, causing the curvature. And over here we have the corpus. Firm outer casing where the plaque forms Peyronie disease. So the firm outer plaque, this is the corpus and this is the firm outer plaque over here. It is the firm outer plaque forms in the Peyronie disease. So abnormal tunic albuginea localized fibrosis, it is acquired disorder caused by the trauma in the susceptible individual. So whenever there is trauma, there is a chance of developing Peyronie disease. It may cause pain, nodule, abnormal curvature when erect, and erectile dysfunction. Treatment is with a pentoxifylline. Okay, so what does that do? Pentoxifylline is a phosphodiesterase inhibitor. It reduces the inflammation and prevents the collagen deposition. So pentoxifylline is used for the treatment of Peyronie disease. So then we will move forward to the urethral injury. It occurs almost exclusively in men. Specific if the blood is seen at the urethral meatus. The urethral injury, it happens almost exclusively in the men because urethra is very small in the females. So in the male, since the urethral pathway is very long, so that can lead to the urethral injury. And with respect to the blood is seen at the urethral meatus, urethral catheterization is relatively contraindicated in these patients. Okay, so anterior urethral injury, and then we have the posterior urethral injury. Part of urethra. So we are talking about the anterior urethral injury, which is this one. So in this, the part of urethra that is damaged is the bulbar or the spongy urethra. So here you can see that the part of the urethra that is present inside the corpus spongiosum will be damaged, and if it is damaged, so the spongy part of the urethra is being damaged. So perforation of the spongy urethra lead to the rupture of the Buck's fascia, and then if the Buck's fascia is being damaged, so the urine can start accumulating around the penis, and maybe it is also starting to accumulate in the scrotum area. So here you can see the mechanism, the perineal straddle injury. Okay, straddle injury. I don't know what that is. Let's see that straddle injury. So the straddle injury is like when you are like cycling or something maybe. So it can result into straddle injury. Or a straddle injury, genital trauma occurs when a female hits the vulva or perineum, external female genitalia, on an object, and force generated by the weight of her body causes an injury. This can occur during a fall or accident. Vulva includes the labia minora, labia majora, and the clitoris. So straddle injury can happen in males as well. So mechanism is a perineal straddle injury. Location of the urine leak accumulation, blood accumulates in the scrotum. Okay, so leakage of the blood or urine. So the blood will accumulate in the scrotum. Okay, so the blood is accumulating within the scrotum, while the urine, if the Buck fascia is torn, the urine will escape into the perineal space. So for the blood, remember the blood is accumulating in the scrotum, and if the Buck fascia is torn, the Buck fascia is surrounding everything basically. So if the Buck fascia is torn, so resultantly the urine will escape into the perineal spaces. Presentation is blood at urethral meatus and scrotal hematoma. So there will be scrotal hematoma and blood at the urethral meatus. So this is the finding of anterior urethral injury, and then let's talk about the posterior urethral injury. The part of urethra that is damaged is the membranous urethra, like just next to just before entering the corpus spongiosum. So that is not spongy urethra, that is just prior to that, and you may say that just distal to the prostate. So if it is damaged over there, mechanism is pelvic fracture. The location of the urine leak or blood accumulation is urine leak into the retropubic space. So it is basically, this is pubic bone, and it is leaking into the retropubic space. Then the presentation is blood at the urethral meatus in high riding position. So the blood will be at urethral meatus and high riding prostate. So prostate will move upward, because suppose that prostate was lying at this particular level. Now there is accumulation of the urine under that, so this will push the prostate to an upper level. So there will be high riding prostate that can be seen on the CT scan. Along with that, blood at the urethral meatus will also be present. Then we have anatomic innervation of the male sexual response. So point, squeeze, and shoot. So anatomic innervation of male sexual response. The erection is basically a parasympathetic. Erection is mediated by the parasympathetic nervous system, that is pelvic splanchnic nerves S2 to S4. Nitric oxide increases the cGMP that leads to smooth muscle relaxation that causes vasodilation, and it is pro-erectile. So nitric oxide is pro-erectile. Parasympathetic is pro-erectile. So what happens that pelvic splanchnic nerve, which are supplying like S2 to S4, they will lead to the increased production of nitric oxide, which increases the increased cyclic GMP production and smooth muscle relaxation, vasodilation, and pro-erectile. So we can give the phosphodiesterase 5 inhibitor, for example, sildenafil. What? Phosphodiesterase 5 inhibitors, sildenafil, they will decrease the cGMP breakdown. Yep. So when the cGMP breakdown is less, so that will lead to a prolonged state of erection. That is, this is the the mechanism of action of the Viagra drugs. So we are not supposed to give the phosphodiesterase 5 inhibitors along with some nitric oxide medication, because the people who have erectile dysfunction are normally geriatric population, and they are also commonly hypertensive as well. So if they are taking some hydralazine or some other nitrates, along with that we prescribe them the phosphodiesterase 5 inhibitors, they can develop serious hypotension. So we are supposed to take a good medical history of the patient before giving them any kind of drug. So norepinephrine, it increases the calcium influx that causes smooth muscle contraction and vasoconstriction, that is anti-erectile. So norepinephrine is anti-erectile, while nitric oxide, that is like phosphodiesterase 5 inhibitors, or the parasympathetic innervation, that is pro-erectile. Then emission, that is sympathetic innervation. Emission is sympathetic nervous system, hypogastric nerve T11 to L2, and ejaculation, visceral and somatic nerves, the pudendal nerve. So the ejaculation is mediated by the visceral and somatic nerve of the pudendal nerve. Uworld point about the prostatic plexus. So the Uworld point about the prostatic plexus lies within the fascia and prostate and innervates the corpus cavernosa of the penis, which facilitates the penile erection. As a result, the prostatectomy or injury to the prostatic plexus can cause erectile dysfunction. If there is any injury to the prostate plexus or prostatic plexus, it can result in the erectile dysfunction. So prostatic plexus lies within the fascia of the prostate and innervates the corpus cavernosa of the penis, which facilitates the penile erection. As a result, prostatectomy or injury to the prostatic plexus can cause erectile dysfunction. Moving forward, we have seminiferous tubules. So inside the seminiferous tubules, I guess there is a picture of that as well over here, or maybe where is that picture? I'm looking for a spermatogonia, like it is not mentioned over here. So we are talking about seminiferous tubules. Let me take a screenshot of this first, and then we'll talk about it. I'm sorry, actually I was taking screenshot in the previous recording as well, like in part 4 as well, but my OBS was at the window capture mode and my screenshots were not recorded, and that is why you may find some points where I was kind of zoned out. I was talking about the screenshot which were displaying to me, but they were not apparent on your screens. So I'm sorry for that, and you are recommended to open the PDF version, because I always put the description link of the PDF. So whenever you are listening to the recording, so open the PDFs alongside, so that you can listen to me and you can also see the visuals, maybe the small times which I make. But along with that, you could also go with the PDF version, so that you don't miss out on anything, because I'm very new to this recording thing, and I have I'm kind of newbie. I'm learning every day, so I hope to make the experience better every day. So let's do it. So yes, there we go. So we're talking about the seminiferous tubules. Let me zoom it in, and sometimes my laptop just it's not ready to respond. Okay, so spermatogonia, the main germ cell pool, and produces the primary spermatocytes. So the main germ cell pool and produce the primary spermatocytes. They line the seminiferous tubules, as you can see in the picture A, like in this picture. If I could zoom it in, so the seminiferous tubules, where are they? Seminiferous tubules, they must be somewhere. Okay, there's nothing is visible in this picture. Seminiferous tubules. Okay, I guess I must take a smaller picture. So yes, now I've kind of split these pictures. So the spermatogonia, the location of the spermatogonia is that they line the seminiferous tubule. So this whole structure, like the structure you can see in this picture, like this whole structure is spermatogonium, like this whole picture is of this this whole picture is of the seminiferous tubule. So this is seminiferous tubule and the spermatogonia present like over here, like you can see, if my mouse is permitting me, so you can see over here, so like this is spermatogonia, these pictures in this picture. And if you can see in the schematic diagram, that is the better diagram. So this is a cut section of the seminiferous tubule, and here you can see the spermatogonium which are lining the seminiferous tubules. Okay, moving forward, Sertoli cells. So Sertoli cells, they secrete the inhibin B, and that inhibin B inhibits the FSH. Okay, so inhibin B is responsible for the inhibition of FSH, secretes the androgen binding protein. So inhibin B will inhibit the FSH, and then it secretes the androgen binding protein, maintain the local level of testosterone. It produces Mullerian inhibitory factor. So Sertoli cell, we discussed about that ages ago. We were talking about Mullerian inhibitory factor in the physiology section over here. So here you can see that the Mullerian inhibitory factor is being produced by the Sertoli cells, and they are going to inhibit the the growth of the paramesonephric duct, like over here. So paramesonephric duct, the Mullerian duct is not being formed, or the formation of paramesonephric duct or Mullerian duct into the internal female genitalia is inhibited by the Mullerian inhibitory factor, which is produced by the Sertoli cells. So let's come back over here. So so we are talking about the Sertoli cell, they secrete the inhibin B which inhibit the FSH. On top of that, so if you can see the role, okay, let's read it first. So tight junctions between the adjacent Sertoli cells from the blood testis barrier isolate gametes from the autoimmune attack and support and nourish the developing spermatozoa. Okay, regulate the spermatogenesis, temperature sensitive, decreased sperm production and decreased inhibin B with increased temperature. So whenever there is increased temperature, sperm production is decreased and inhibin B production is also decreased. So if I could zoom it in, so here you can see that these are the Sertoli cells. Sertoli cells, this is also a Sertoli cell. This is the Sertoli cell nucleus. So this whole blue structure, like the blue structure with the orange nucleus, is the Sertoli cell, like big cells. So they are producing inhibin B. Inhibin B will be inhibiting the FSH. Okay, so FSH was stimulating the Sertoli cell, and Sertoli cell give a negative feedback loop to the FSH production. Okay, and Sertoli cells are responsible for nourishment of the spermatogonia, and they also provide the blood testis barrier for the immunoprotection of the cells. Tight junction between the adjacent Sertoli cells from the blood testis barrier isolate the gametes from the autoimmune attack. MIF production, inhibin B production, they secrete the androgen binding protein, maintain the local level of testosterone. If they will produce the androgen binding protein or the testosterone binding protein, so they will maintain the local level of testosterone. Okay, then support and nourish the developing spermatozoa, regulate the spermatogenesis and temperature sensitive, so decrease the sperm production and decrease the inhibin B and increase the temperature with increased temperature. Okay, so I guess this is no more needed. Let's keep it over here. So they line the seminiferous tubules. They also line the seminiferous tubules just like the spermatogonia. So if you can see in this picture, spermatogonia, the pink cells which are lining are spermatogonia, while the blue cells which are lining are the Sertoli cells. There are non-germ cells, so they convert testosterone and androstenedione into estrogen via aromatase. They can do that. So they convert testosterone and androstenedione into estrogen via aromatase. Sertoli cells are they support the sperm synthesize and inhibit FSH. No. Sertoli cells supports sperm synthesis and they also inhibit FSH. Then homolog of the female granulosa cells. So you must remember these things, the homologous areas. Sertoli cells are homolog of the granulosa cells in the females. We will talk about that when we will discuss the histology of the maybe pathology. So Sertoli cells, pardon me for the handwriting. So the Sertoli cells are the counterparts of the granulosa cells in the ovary. Okay, so increased temperature seen in the varicocele and cryptorchidism, and if there is temperature is increased, so that can result in this thing, decreased sperm production and decreased inhibin with increased temperature. What is the function of Leydig cells? Leydig cells secrete testosterone. So ladies dig testosterone, there is a mnemonic like that. So Leydig cells secrete the testosterone in the presence of LH. Testosterone production is unaffected by the temperature. So testosterone production is not affected by the temperature. The only thing that is being affected is the Sertoli cell. The sperm production is affected, testosterone remains constant. Like in all the temperatures, testosterone production is not affected by the temperature, but the sperm production is affected. Okay, so Leydig cells secrete the testosterone in the presence of LH. Testosterone production is unaffected by the temperature. So interstitium, so they are present in the interstitium, right? They are endocrine cells, homologous of the female theca cells. So Leydig cell for the theca cells, theca cells. Okay, so Leydig cells are for the theca cells. They are theca cells analog, and LH stimulated the Leydig cells. So LH stimulated the Leydig cells, while FSH was stimulating the Sertoli cell. There was an S in the FSH, and that S was for the Sertoli cells. So that was stimulating that. And let us see this in the diagram as well. So you can see it in, here in the diagram. So where are the Leydig cells? The Leydig cells are like over here outside the seminiferous tubules. Okay, so they are located outside the seminiferous tubule, and they are responsible for the production of testosterone when they are stimulated by the LH. So they will be stimulated by the LH, and then testosterone will be produced, and then that testosterone will go to the hypothalamus and give a negative feedback signal to inhibit the GnRH release and stuff like that. So let's read this diagram. So hypothalamus causes a pulsatile release of the GnRH, and whenever there is a pulsatile release of the GnRH, so the pulsatile release of the GnRH causes the stimulation of the anterior pituitary to release FSH and LH. That FSH will stimulate the Sertoli cells to perform the function, and the Sertoli cells will then produce the androgen binding protein, and then that androgen binding protein will get testosterone bound to itself, and it will maintain the level of testosterone within the seminiferous tubules where the spermatogenesis is taking place. And the LH will act on the Leydig cells to cause the production of testosterone. Testosterone will enter the capillaries and perform the the systemic functions of that. So the Leydig cells are basically endocrine cells. Okay, so because they release the testosterone into the circulation, and then within the circulation it performs all the protein synthesis and stuff like that. So this is happening over there, and then this is the lumen of seminiferous tubules, and spermatogenesis happening like this. Like it starts with the spermatogonia, then comes the spermatocyte, then spermatocytes will spermatogonia, they will be, I guess, primary spermatocyte formed due to the differentiation. I think that there must be a picture of that as well. So but spermatogonia will differentiate into primary spermatocyte. They will undergo meiosis 1 to form secondary spermatocyte. Secondary spermatocyte will undergo secondary spermatocyte will undergo meiosis 2 to form spermatids, and spermatids will then differentiate into mature sperms. Okay, so this is like moving in this direction from above downwards into the seminiferous tubule, then from the seminiferous tubule the 7-up pathway, like seminiferous tubule, then from there into the epididymis, and then into the vas deferens, then to the ejaculatory duct. 7N is for the nothing, and then U is for the urethra, and then P is for the penis. So that is the pathway they follow. So I guess we're done with this picture. So let's remove this one, and let's remove this one as well. Now we have this picture. We discussed that. Now this is a cross section of the seminiferous tubule, and seminiferous tubule, these are the Sertoli cells, like these one with the pale nucleus, I guess. The spermatogonia are over here, and these are primary spermatocytes, then spermatids. Okay, and secondary spermatocytes over there. Okay, so here they've shown it. Like Leydig cells are present outside the seminiferous tubules, and then there is a connective tissue, then the basement membrane, then comes the spermatogonia, which is lining the seminiferous tubules. Then we have the tight junctions between the these are spermatogonia, right? And these yellow cells are the Sertoli cells, and there is a tight junction between the Sertoli cells, and that tight junction provides the blood testis barrier for the protection of the sperm from the immune response or the immune cells. Then the primary spermatocytes over there. So the spermatogonia, they differentiate into primary spermatocyte. They undergo meiosis 1 to form secondary spermatocytes. Then secondary spermatocytes undergo meiosis 2 to form spermatids, and spermatids mature to form spermatozoa. Okay, so I guess there must be a picture, but there's no picture. I can't find it. So let's Google it. Spermatogenesis. So spermatogenesis, here you can see. So this is spermatogonia. Spermatogonia undergo mitosis, or you may say differentiation, to form primary spermatocyte. Primary spermatocyte undergo meiosis 1 to form secondary spermatocytes. Secondary spermatocytes undergo meiosis 2 to form spermatids, and then we have spermatozoa and all that. So I will speak it because I don't have a pointer to write something on my screen. So the spermatogonia, they are 2N 2C cells, right? Because they are just like somatic cells of our body. So they contain 2 copies of each chromosome, and a total of 2 chromatids, because there are 2 copies. So each chromosome is a single chromatid chromosome, so there are 2 total chromatids. I will draw that later on in the PDF as well. So let's draw it, because I guess the mere audio version is not enough. So let's add a page. So here we have it, like let's draw the picture. So these are the spermatogonia. Spermatogonia, they undergo mitosis or differentiation to form the primary spermatocytes. Primary spermatocytes, they undergo meiosis 1 to form secondary spermatocytes, like 2 of them. The secondary spermatocytes undergo meiosis 2 to form spermatogonia. They form primary spermatocytes. Primary spermatocytes undergo meiosis 1 to form secondary spermatocytes, and the secondary spermatocytes led to the formation of spermatids. Yep, spermatids, like 2 spermatids for each secondary spermatocyte. So a total of 4 spermatids are formed, like this, and here we have another one. So 4 spermatids are there, and then each of them will mature to form a sperm, and sperm will look something like this. And here we have 4 sperms which are formed out of spermatids. So there is a better picture which we have already seen in the Google. So this the point of this picture is not that this description, like which one is spermatogonian, which is the primary, secondary spermatocyte. Just remember this one. So now I will just speak it and just remember what I am speaking right now. So in the case of spermatogonia, these cells are just similar to the somatic cells of the body. So they are 2N, 2C. What does that mean? Let's suppose this is chromosome number 1. So it will have 2 copies, like maternal copy as well as the paternal copy, and these 2 copies will be monochromated chromosomes, which means that there are 2 copies of chromosome number 1. On top of that, a total of 2 chromatids are also present, like 1 chromatid and another chromatid. So there are 2 chromatids for each chromosome. Clear? They undergo mitosis. So the primary spermatocytes, they are also 2N, 2C, just like the spermatogonia. Now there will be meiosis 1. After meiosis 1, the cells which are formed are called secondary spermatocytes. Now these secondary spermatocytes are just give me a second. Just make a small correction over here, like it was not much of a mistake, but I want to make it a bit more clear. So remember that the spermatogonia are just like the somatic cells, and they have 2N and 2C, correct? Secondly, the primary spermatocytes, initially they have just like 2N and 2C, but before undergoing meiosis 1, there is an S phase, and during the S phase we know that there is DNA replication that is taking place, and that DNA replication will lead to the number of chromosomes will be 2N, like there will be 23 pair of the chromosomes, but instead of 2C it will become 4C. Let us draw it over here. What it will look like? Suppose this is chromosome number 1, a pair of chromosome number 1, they will become dichromated. It is not a technical term or something, I am calling them dichromated. So now how many chromatids are there for the chromosome number 1? Like 1, 2, 3, 4. So there are 4 chromatids for the chromosome number 1. So now this situation is called as 2N and 4C. Like we have 4 chromatids for each chromosome. For chromosome number 1, there are 4 chromatids which are representative of chromosome number 1. You can take it like that. Then they divide to form primary spermatocytes. Now when they are primary spermatocytes, in the meiosis 1, half of the chromosome will go to one cell and half of the chromosome will go to the other cell, but there's so they will do like this. So let me remove that because I have a small space. So now these cells are like 1N but 2C. Why so? Because now for chromosome number 1, we have only one pair of chromosome, like one dichromated chromosome went to this cell and the other chromosome went to this cell, and this also has like a pair, like something like that. So in each cell we have half the number of chromosomes, like only 23 chromosomes are there. 23 pair are not present now, only 23 chromosomes are present. On top of that, each chromosome is a dichromated chromosome, so there are 2 chromatids for each chromosome. So remember this one. So that is why we are writing it 2C. Now as they go further meiosis, like meiosis 2, so these chromatids will be split half and each cell will get one copy. So now each spermatid will be 1N, 1C. That is, they have 23 chromosomes, unpaired 23 chromosomes, and each chromosome is a monochromated chromosome like this. So this is it. So before going to a clear picture, I want to highlight that the stereotypical, or the conventional picture of the chromosome which is drawn in the biology books, or maybe you have seen in some animations or stuff like that, they always draw it like that. It is not a chromosome. Like, it is not a characteristic picture of the chromosome. It is the replicated version of the chromosome just before going into the cell division. This is what a chromosome looks like. The single monochromated chromosome, this is unreplicated chromosome, and whenever it is going to enter the cell replication, it replicates to duplicate it. It duplicates itself. Okay, so now the two chromatids are attached to the centromere. This is a duplicated or the replicated version of the chromosome. So other than that, normally the chromosome is this. So whenever we call 1C, this is this chromosome, or even 2C, so it means there are like two chromosomes of this etiology. So remember these terminologies. Go to some like video or picture. I guess you'll get a lot of good videos on YouTube about this one. If you could not understand this one, so look for a better picture or better explanation. So here is a good picture from first year 2022. I guess the version, the PDF which I am studying right now, it was not present in that one. So let's see it here. Here we have 46 chromosome, which is 2 and 2C in the spermatogonia. They enter the area of proliferation by binding the tied, by moving across the tied junctions in the blood testis barrier. Now there are 92 sister chromatids, which mean that 92 sister. I will explain that. So the primary spermatocyte are diploid, like there are 23 pair of chromosomes. So 23 pair means like for each chromosome we have 2 copies. Okay, so this is the duplicated version I'm drawing. So these are 2 copies for each chromosome. And how many pairs, how many sister chromatids are there? There are 92 of them. Suppose that for each chromosome we have how many? We have 4 chromatids and we have a total of 23 chromosomes. So if we multiply 23 by 4, so we get 92. So 92 sister chromatids are present, and sexes are XX for the female and XY for the male. Secondary spermatocyte are 1N and 2C, which means that this goes into one cell and this goes to another cell. So chromatids are still 2, but there are 2 chromatids, but the number of chromosomes have become half. 46 sister chromatids and 46 sister chromatids. Now in the spermatocyte that is haploid 1 and 1C, we have like monochromated chromosomes and half in number in each cell, and ultimately that leads to maturation or spermatogenesis or spermiogenesis. So this whole process is called as spermatogenesis, and this process of conversion of spermatid into mature sperm or mature spermatozoa is called as spermiogenesis, in which it requires the acrosome and the tail and head, nucleus, neck and middle piece, and all of these structure middle piece contain a lot of mitochondria. So this variation happens. This process is called as spermiogenesis. I guess we have spent a huge chunk of our time on this, but I guess it is worth it if I could explain that. So kindly let me know in the comment section that if you could understand that or not. So if you could not understand, so you can make some other video on that as well. So let's go to the vasectomy. Vasectomy is a virilizing procedure. So transaction of the vas deferens blocks the transport of new sperms from the epididymis but has no effect on the sperm distal to the ligation. Viable sperm may persist for 3 months and at least 20 ejaculations following vasectomy. So let's draw the pathway. Not draw the pathway, just make it 7 up, SE V E small n. Then we have up. So 7 up means firstly there will be seminiferous tubules. Okay, then it is epididymis. Okay, then the vas deferens. So this is the point where we are going to ligate the pathway. So epididymis, and you can see the vasectomy transaction is at the level of epididymis, at the level of junction between epididymis and vas deferens. So we are cutting the vas deferens basically. So the sperms which are being produced in the testis, they won't be able to reach the epididymis now, but the sperms which are already present in they won't be able to reach the vas deferens, but the sperms which are present already in the vas deferens or in the urethra or in the in the penile shaft or something, so they will still be there, and they will be viable sperms, and the person must wait for at least 3 months or at least 20 ejaculation following the vasectomy to be completely sterile. Sexual intercourse may be resumed within a week following the procedure. Sexual desire remains same or decreased anxiety about pregnancy. So the sexual desire has increased because there is no anxiety about pregnancy. No effect on attaining and maintaining an erection. On ejaculate volume, sperm is only 2 to 5% of ejaculate. So effect on the Leydig cell of testosterone production. Okay, wait a minute. No effect on attaining or maintaining an erection or ejaculate volume, sperm is only 2 to 5% of ejaculate. So since the sperm is just 2 to 5% of the ejaculate, the major chunk of the ejaculate is coming from the prostate and other accessory glands. So the ejaculate volume is not affected. On top of that, erection is not affected, and there is no effect on the Leydig cells or testosterone production. Got it. So then we have some vesicle, blah blah blah. So remember this one, and then we have the anatomy of the ureter. So anatomy of ureter, we will discuss this anatomy in the next section. It is very important to remember the pathway. So here you can see that it is passing under the ovarian artery. It is the ovarian artery, right? No, it's not ovarian artery. So it is passing under the gonadal artery, which would be somewhere over here, and then it passes over the iliac arteries, then under the round ligament, and under all of the ligaments of the ovary, including the that cardinal ligament that was connecting the cervix to the pelvic wall, and then here we have the artery. I guess I don't know which artery was that. So but it was passing under all the structures, but we will see that in detail. So remember that ureter is to be kept in mind whenever we are talking about pelvic surgery, or whenever we're talking about hysterectomy or oophorectomy and stuff like that. Whenever they give you things like that in the question stem, be cautious that they may ask you now about the injury to the ureter. So because this is very important, because of the fact that this is the tie between the reproductive and the renal section. So that is why they sometimes ask you on and test you on that. So keep these things clear in your mind, and see you in the next section. Until then, Allah Hafiz.